So first, thank you very much to Tom, Chris, Mike, everyone who's put this together. It's not easy to organize a conference focused around new ideas, bringing together people from a few different slices of industry. They've done a fantastic job and have been incredibly helpful throughout. So thank you guys very much for the invitation and for putting this together. This is all right, good. So first, my disclaimers. Co-founder of a for-profit venture called SIFT, assistant professor at Brigham and Women's Harvard Medical School. Also have affiliations, vested interests with every other organization pictured in the slide, so feel free to not trust a word that I say. So I have spent the last dozen years or so in the health system innovation space, working with a number of organizations, trying to help them use their data differently to improve the quality of care, the quality of clinical operations, even the quality of scientific discovery. And I feel very fortunate to have been able to work on some pretty cutting-edge projects, like at the Department of Veterans Affairs, the Million Veteran Program, which has just hit 550,000 plus veterans enrolled to do genomic science very differently. Also had the fortune of leading the Point of Care Clinical Trials Program, where we jammed clinical trials into the electronic medical record for the first time in an effort to reduce the number of years between scientific discovery to implementation from now an estimated 17 down to the minute you have enough evidence, you can flip a switch and turn that into decision support. And more recently, I worked with Atul Gawande at Ariadne Labs, and we got to do some really fun stuff in Uttar Pradesh, India, where we were taking data feedback loops captured from cell phones, sending it up to an Amazon cloud, and then delivering it back to birth attendants and coaches so that they could work with the birth attendants to improve upon really basic life-saving behaviors like hand washing and breastfeeding and skin-to-skin contact. And while I feel blessed to have been able to do that work, it's also been bittersweet, if not disappointing. I think the reason we choose to apply these skills to make data matter for healthcare is because we all believe that there is an enormous opportunity to improve lives by doing this in healthcare as opposed to in other industries. And if you've been in the field for some time, I think you may also share my frustration in watching other industries fly past us when it comes to using their data most effectively. Every time you walk down the aisles of a supermarket, every item you're seeing, where it's positioned, when it's restocked, is dictated by the collective experience of shoppers who have come before you. They use their data to understand what's happening, to whom is it happening, what should we be doing more of, what should we be doing less of. Casinos know exactly when to offer their players some kind of incentive to keep them at the table a little longer, a steak dinner, a free room to get them to come down to Connecticut or whatever other part of the country you're in. Even Waste Management has figured out how to optimize their routes to make sure that they're spending every dollar they have as effectively as possible. They can predict landfill overfill years in advance based on the collective experience of neighborhoods like yours. And the terrible tragedy that we're all overly familiar with now is that despite the fact that no industry counts more than healthcare, it truly is the one industry that's a matter of life and death. You'd be hard-pressed to find an industry that counts less than healthcare. We simply have not used our data, our collective experience from delivering care, to improve the quality of care we deliver. And I think a set of numbers that is probably most damning, disappointing, revolves around the number of people that die of a preventable death each year. So the Institute of Medicine estimated that number could be as high as 98,000 some 15 years ago. And then a couple years later, the Journal of Patient Safety, this is actually just a couple years ago, the Journal of Patient Safety had a study that said that that number might be as high as 210,000 people dying by accident at the hands of the US healthcare system, but the upper bound of that estimate may be 400,000. And while there is considerable debate around what is an accidental death, and healthcare is complex, have you heard the analogy that it's the equivalent of two airplanes, a DC-10 and a 747 going down every day for a year is the equivalent of the number of deaths. Third leading cause of death now in America is preventable death at the hands of the US healthcare system. And that number may be 98, it may be 400, it may be 210. I would argue that the most concerning aspect of this number and the conversation around it is that we don't bother to count it, right? If something counts, we should count it. And if we're off by a margin of 200,000 to 300,000, it would indicate that it just doesn't matter. I cannot be convinced that, considering the minds in healthcare in the US, we can't come up with a reasonable way to approximate this number with a tighter margin of error than 300,000. And so we've watched from within healthcare at other industries. The light at the end of the tunnel is real, but it has seemed distant for at least 2 decades. The point of my talk today, there's 3. Number 1, I am now convinced, and I'm a skeptic by nature, I'm now convinced that this is happening, and it's happening now, as compared to the dozens of false starts that I and you have experienced up till this point. The second point I'm going to make today is that the return on investment of big data approaches will be even higher than those in other industries. And that may seem a stretch, because right now we don't even do the math on the number of people that are dying by accident, but I'm going to argue that in a few years' time, these big data technologies will be even more important for us than for waste management, retail, casinos, telecom, etc. And the final point that I'm going to make today is that our current approach to analytics will change dramatically as a result, to the point that I would estimate in less than 5 years, we will look back and laugh and maybe be a little uncomfortable at what we were considering in analytics right now today. So, let's start with why now as compared to in the past. 2 conditions are necessary for data to take on new life in healthcare. Number 1, access to the data. Number 2, incentives. To understand why this is happening right now, we start with a healthcare policy story. Healthcare policy is terrifying and boring. I'm going to do my best to make this matter in 3 minutes or less. And the reason you should care about it is because in healthcare, policy eats culture and strategy for breakfast. If you don't know healthcare policy and you're in the healthcare business, enjoy your stay, it'll be temporary. Okay, here we go. President Obama takes office, and one of his top priorities is to improve the quality and lower the cost of healthcare provided. Why? Because somewhere around the 80s, we moved from an HMO model to more of a fee-for-service model. And in a fee-for-service model, you get paid for the number of units sold. The quality, the efficiency, not part of the formula. So understandably, the cost of care goes through the roof, and we're by far and away number 1 in the world now, 37th in terms of the quality of care we provide. Opportunity window opens. In 2008, the Great Recession hits. There's blood on the economic streets. Great opportunity for a politician to push through a number of policy agendas. He starts with data access. He starts with a carrot and stick policy that ensures that this country begins to adopt digital electronic medical health records at rates that have never before been even considered. Right? So the American Recovery and Reinvestment Act, $17,000 per adopting clinician, but if you wait 4 years, it's minus $4,000. What happens? Everyone gets an electronic medical record, right? In less than a decade, when I started this work, we had 6.7% adoption of electronic medical records. Now we're up in the mid-90s, depending on how you count it. So we've got data in ways that we never had in the past. What about incentive? Right around the time all of this adoption of electronic medical records stuff is happening, the same administration introduces payment reform in ways that we've never seen before, right? Now, it's not smooth, it's not easy, it's not even one flavor of payment reform, but the writing is on the wall. Suddenly, the quality and the efficiency of care provided will be part of the formula that dictates how you get paid. So, are you still with me? We did healthcare policy. Is everyone still with me? Yes, okay, good, because I have more healthcare policy for you. Okay. I made the argument in favor of data being accessible. I made the argument that we now have incentive. Why am I arguing that the ROI will be even bigger in healthcare than in other industries? So let's pick up policy again, but let's start by saying, while every other industry has quantitative and at least somewhat reliable data, right? I trust the number of iPads I sold in Wisconsin. I trust the share price of that particular stock. Healthcare data, as you all know, is very different. Why is it so different? When you incentivized the rapid adoption of electronic medical records, where if you don't have this in place in just a few years' time, completely transformative, and you need to do it now, which electronic medical record vendors do you think get the money? It's the folks that have been in the field for 30 years. And they did not grow up creating electronic medical record systems designed for value-based care. They created electronic medical records for fee-for-service care. What are the 3 reasons for being for electronic medical records in a fee-for-service world? Number 1, capture the number of units delivered so you could get paid. That's claims data, right? Number 2, communication among clinicians. I'm a nurse, I'm picking up a shift of another nurse. How am I going to communicate across clinicians what happened? How do we communicate as humans? Free text, narrative, storytelling. Greater than 50% of the electronic medical record is free text, unstructured, inaccessible to a lot of the techniques we currently use. 3rd reason for being, legal documentation. So not only am I dictating in free text, but I'm adding this layer of ambiguity that would protect me and my institution from legal action in case my opinion or my actions are not correct. So I'm taking free text, I'm making it even harder. Notice, completely missing from the reasons for being for the electronic medical records that we have been adopting over the last 30 years and aggressively today. Learning, doing the math, counting, improvement. Value-based care is not introduced with one agreed-upon set of guidelines. Instead, dozens of policies are introduced all at the same time, causing healthcare to exist in a quantum state of payment reform. There are several flavors of ACO. Commercial payers come in behind it and take advantage of this, finally an opportunity to dictate, to have some control over cost and efficiency. They introduce AQCs, right? CMS puts out APMs, alternative payment models. The same hospital caring for the same population of diabetics could be held accountable for 5 to 7 different methods of reimbursement, depending on who's paying. Each one of these comes with it a set of reporting requirements. That leads to checkboxes, drop-downs, process measures, which take our already poorly designed 30-year-old electronic medical record system and add to it another layer of confusion, frustration, another layer of data not designed to help you do your job in analytics, getting us to this value-based future. So this leaves us with data that is just plain harder and different than the data we see in other fields. Which leads to the 3rd argument that I wanted to make today, which is these big data methods will matter even more for us than they have mattered for any other industry that has already made terrific use of them. So this is happening in healthcare. So let's now talk about big data. Raise your hand if you're involved in big data in any way, please. Leave your hands up if you've explained to someone that you're involved in machine learning. Leave your hand up if you've called it artificial intelligence, cognitive computing, data science. We have a naming issue here, right? We've just created this umbrella term that means anything that has to do with data that maybe isn't in Excel. It's confusing. It's confusing the customers, frankly. It doesn't have to be that hard. We're talking about a new set of math plus computation. It has with it a set of pros and cons. It is an objective set of technologies that, applied to the right tool, can lead to answers to questions that we can't currently answer with our current approaches. So let's ground our understanding of what this is with a pretty simple example, looking at the way we currently learn from data. As we move to a value-based model, this is one of the thousands of questions that will dictate the success of your organization. It's no longer about what happened in the past. It will soon be about what is likely to happen. And so what are our two methods of learning from clinical data today? And by clinical, I mean claims or EMR data or whatever data we have. Our two methods are, number one, reporting. Reporting was designed and has served us well to give us a view to the past. Perfectly well suited to look at claims data to answer questions like how many beds, how many pills, how many cuts. These are the questions that I trust in attempting to get answers out of claims data, because that's what they were designed to answer. And so our clinical team now comes to us, the analysts, and asks us to answer questions like, how many diabetics are we likely to see? Which diabetics exactly are most likely to? And we take the limited structured data we have, and we attempt to use intuition, clinical intuition, good old-fashioned smarts, to map that to the structured data that we have in our databases, right? Our second method of answering that really important question is traditional statistics, logistic regression-based risk scores. LACE, LACE Plus, Johns Hopkins, there's a dozen plus vendor products. Is this familiar to folks? Okay. So, it's always dangerous to try to drop a whole bunch of methods into just two buckets, but at a high level, what we're doing with risk scores is we're working with one or more institutions, mostly claims data, and we're attempting to, in advance, say that there's probably 10, 5, 7, a dozen things that matter here, and we're moving each one of those items a little bit to the left, a little bit to the right, and we're seeing if that affects our statistical significance, if it changes the underlying characteristics of the population, if just a little bit. And we're validating that mathematically. Then, because up till now, we want to take that risk score and apply it as widely as possible to as many organizations as possible, we turn it into a set of rules. 1 point for this, 2 points for this, 3 points for a readmission within 6 months, 5 points for side-brain glioblastoma, whatever it is, right? So I want to talk about some of the limitations of these methods and why I think some of the newer methods will become very important complements, in some cases replacements for the way we currently learn from our data. Number one, there is a heavy dependence on disease codes. I trust, and I say this as a researcher who's been doing this for some time. I'll give you a quick anecdote. We work with 6 major academic medical centers, very shiny ones, well-known, winners of some best in the country awards, to try to understand and improve the quality of colorectal cancer care being delivered. Every effort to do things better starts with who should be in the cohort. What do we use to figure out who has a disease? ICD-9 codes, right? 6 academic medical centers, 80% of the people that had the codes for colorectal cancer never had the cancer, right? All of them had colonoscopies, 20% had the cancer. Working as a researcher in data for a dozen years, I can tell you that this is not the exceptional case. Just a couple months ago, I was working with an ACO. I told this story. The CMO said, no way. The guy responsible for revenue recognition had just finished doing an audit on heart failure and said 50%. 50% inaccurate in heart failure today in our organization. That's disease codes. That's a problem if we're going to try to use them to predict what's likely to happen in the future. Relatively little data points considered. Ask your clinician to look across a population at who needs their help. I would be amazed if they pull up claims data and look at 5 to 7 data points as opposed to looking the gestalt of the medical record that they have at their disposal, starting with the notes. Risk scores are often one size fits all. Clinicians also would not apply one set of thinking, one algorithm, one scoring system to an entire population to understand risk. If you're using a risk score-based approach to consider a high-risk pregnancy with exactly the same math as you would consider a geriatric nearing end of life, you're probably being a bit less granular than I think the patient population would require. We're ignoring free text today with most of these methods. And I hear this a lot from the work that I do. Doctors tell us, I know who's sick, I need to know who's actionable. I know who cost more last year. I need to know which of my diabetics is most likely to end up in the emergency department soonest. And one step further, I already know these 5 people, I'm going to see them either way. Tell me who's pre-diabetic that's heading toward diabetes. That I can do something about. That's very different than one-size-fits-all risk models, where you build a model down in rural Pennsylvania and you tell folks in Manhattan that it's good for everyone to understand what's likely to happen. This is one of the approaches I think that we're going to get a kick out of looking back at in just a few years. The final thing that's been heavily influential in my thinking about risk in healthcare is that the patient population and the interventions we deliver are dynamic in nature. So this study came out of Colorado. It was published just last year. They created a cohort of super utilizers in their Medicaid population. Super utilizers end up consuming the vast majority of the resources. What they found is just 7 months after defining this cohort, 50% of that cohort had moved on. They got better, they died, they left. 1 year later, only 28% were left. 2 years later, 14%. If you're building a model that assumes it understands the way the world looks like today and gives you a list of patients today, you need to know that that model is outdated just a few months later. So this is why, some 8 years ago, I began my research in what methods might help us understand what's likely to happen more effectively. And supervised machine learning, as a set of tools, have characteristics that are objectively better at answering some of the types of questions that will matter more in a value-based world. So I want to move away from big data and talk about supervised machine learning specifically, which I believe is one of the most important sort of technologies within the big data umbrella. Rather than begin with who will utilize, supervised machine learning begins with the definition of a cohort, and it splits it in half. Give me the diabetics that did end up utilizing in the very recent past, and give me the diabetics that did not. And then rather than assume that it's going to be these 4 drugs, these 3 conditions, these 2 comorbidities that may matter, supervised machine learning takes an inductive view of the world. It learns mathematically what is it that makes the folks in the that end up in the ED different than the folks that do not. And in doing so, it can consider all available data, right? From your socioeconomic status, to your labs, to your EMR, and if you combine it with natural language processing, the free text, nurses' impressions, call center notes, and so on and so forth. It maps each of these millions of data elements in space using probabilities depending on the algorithm, and honestly, many of these algorithms are completely interchangeable. What really matters is the robustness of the data. And when we say big data, I can tell you we can do this work with as few as a few hundred records, which is contrary to popular belief because, if no other reason, we use the expression big data. But really, it's about rich data and learning from that rich data what matters, or at least what is correlated to one outcome versus the other. Now, if you build these models and you validate these models, then you can apply them to a population in which you don't know the answer, and you can get out of this the rank-ordered list of the patients most likely to be the diabetics that are going to end up in the ED. So what are the characteristics of these types of approaches that make them more attractive for some of the type of work we now need to do in healthcare? Number one, it considers more data than traditional risk scores. The limited data you see on, I don't know if it's the left or right, I guess your left, this is right out of LACE, which is one of the more popular risk scores. If that person that we're trying to predict this for is a high-risk pregnancy, they're a ghost to your risk score because they don't have those criteria that you see on the left, right? If instead, regardless of the condition, we're trying to predict who's going to end up in trouble, it makes more sense to have more data to attempt to predict something. They're also more tolerant to missing and inaccurate data. And by the way, if you work in healthcare, that's our data. And then, remember we talked about how the population moves, right? So if you do something to improve upon a condition, if you turn your case management team loose to try to prevent admissions of folks with COPD, I can tell you that based on what they do, the reasons people come back in, get admitted with COPD is going to change, right? It's going to work. They're going to start winning and solving the problem, and then the reasons you need to pay attention is going to shift. These models, by design, evolve. Machine learning, right? They don't take a static view of the world. They can be retrained with each new experience or periodically so that as your clinical teams are doing their jobs, the models can keep giving them the most actionable people, as opposed to the complaint that we're probably all used to hearing now, which is, I already know about that person, there's nothing I can do, or that's old and outdated. Now, I think it's important to qualify that we're not talking about anything new here, right? Machine learning and the math we're talking about has been around for 40 plus years. In fact, in medicine, across dozens of clinical domains, from surgery to oncology to radiology, there have been hundreds of studies that have shown that these methods outperform traditional methods when it comes to predicting what's likely to happen. Right? The math has been done, that game is sort of over. And if we're going to move toward a value-based model, we need to move past what happened and up and to the right of what's likely to happen. The number of insights that we need to generate, you can't put a number on it. The number of questions you'll need to be able to answer when you are given $25,000 per patient with knee surgery to get them healthy again, you will not be able to settle for who's at risk. You'll need to be able to answer tons of questions, and you would not presume to be able to answer them with a few elements from your claims data. You will need to be able to make sense of all of your data. In fact, for the first time, it will become your competitive advantage. And if you can't take advantage of your data, you will be at a disadvantage. So in my opinion, we've covered the incentive, we've covered access to data, we've covered the tool. I believe the last barrier that needs to be overcome is this idea of democratization. So every technology starts out mystical and accessible to only a few PhDs or experts that live in white sterile rooms and have white coats. And they're the only people that get to use the mainframe computer. And we don't really know what that mainframe does, right? It might be good for accounting, but I'm not so sure. One thing I'm sure of is personal computing will never be important, right? I mean, think about it. It's mystical and magical and exclusive. Eventually, it becomes the desktop computer, right? And then eventually a laptop. And then we get to a point where we're filled in a room full of people that care about big data, and not one of them is walking around without a cell phone, and not one of those cell phones doesn't have dozens of apps on it that let you, the person that has the problems that you want to solve, use the technology to solve the problem quickly, inexpensively, and based on your priorities, not on the dictated few priorities of others, whether those others are government or payers, etc. That's where we need to get in order to truly make healthcare count. And I was looking back, so I've been at this has been the problem that I've been focused on as a researcher for about 8 years now, is the democratization, because math is math. But to make it work for healthcare, there's a whole set of issues that have yet to be tackled that I and many others have been working on. And so I found this quote from a paper that I wrote in 2011, and I guess it's appropriate, but it's also disappointing. I started a paper that I wrote by saying, despite 40 years of promising performance, very few natural language processing or machine learning systems contribute to medical science or care. And this is some of the work that me and my team have been involved with, 15 studies where we're from 250 plus hospitals, 18 health plans. Every one of these exercises has been an effort not really to move the needle up on the prediction, but to move the technology down to the folks that can make use of it. And these are some of the problems you need to solve. You have to become useful. You cannot settle for a one-size-fits-all approch to understanding data. Could you imagine for a minute if Toyota used exactly the same approach to their data as Honda in trying to build cars better, faster, cheaper, and at nicer price points, right? Where's the competitive advantage to that? But that's been the norm in healthcare. But if we switch to value-based care and we truly create incentives toward quality, it's really going to come down to who can use their data to do a better job faster and cheaper. Can't ignore the free text, must be interpretable. The downside on these methods, they do lend themselves to black box results. That must be solved in order to make this stuff useful. And finally, math is math, software is a different animal. In order to make this work, it must be software. So we worked as researchers for a number of years, and then this one paper was an interesting milestone for us, because we do these bake-offs in computer science where everyone gets 3 months to take the data and do the best that they can. with the same set of training data to solve the same problem. And then they submit the results blinded to judges, which is always scary, but it's really the only way you figure out how good you are. So I was early on in my research career and was a little nervous when I submitted the results, because we took the training data the day before the results were due, and we were competing against 22 teams from across the world from very prestigious universities. And we're trying to automatically identify from the free text of 3 hospitals' electronic medical record systems all problems, all treatments, and all tests. And we would be measured, blinded, by the same bar that everyone else would be. We took the data on the day before the results were due. We pressed a button, we submitted the results, and I prayed to God that I wouldn't be laughed out of my academic field. We did not win. But we came in 11th, a couple points off the leader. And that was the argument that we have been trying to make, is that we're past the point of this set of technologies needing to be exclusive to a few. It's time to democratize it. So we made it open source, we gave talks, I wrote papers, I very naively thought I would change the world. I eventually became frustrated with the fact that that's not how the world works. We commercialized this stuff, and I'm going to talk to you a little bit about some of the work that we're doing. And some of these results are from research, some are from industry. In any case, I want to show you what happens when you start to democratize this stuff and you don't force people to pick from a menu of what other people think matters. Number one, you start to focus on really specific, narrow problems to answer questions like what really happened. So we work with 6 different hospitals to understand which veterans with PTSD are getting best practice care, right? There are 3 types of care. 2 are best practice. The other is this big bucket of who knows what that we know aren't the best types of care to deliver. The 6 different hospitals claim to be delivering 75% best practice care. We took hundreds of thousands of free text behavioral health therapy notes, and with 96% accuracy, 1 day later, told both the researchers, but then they told their institution that actually no, that number is more like 23%. They write a paper, but hopefully if they do their job right, the institution begins to change the quality of care delivered based on, for the first time, a real quantitative understanding of what's really happening. Second, you start to move past readmission, right, or utilization, and you start to think about really specific problems. So we're working with an organization that's helping hospitals understand more narrow things like non-routine discharge following a very specific type of surgery, total knee, total hip. And we took claims data and a couple elements of the EMR data, and within a very short amount of time, we were able to turn around results that were 6 or 7 points more accurate than anything that had been published in the literature. But it's really not about a few more points, right? Because the reason they're working with us is because they're going to go after hundreds of different problems, and they're starting to roll in electronic medical record data. So they know that the way this industry is going requires them to be more flexible, adaptive, and democratized than the way the industry currently stands. An interesting thing that one of our customers is starting to do, and this is around revenue recognition and HCC work, is their daisy chaining models. So if you want to solve any problem, but particularly around revenue recognition, first you've got to identify the diabetics. That's a model, but it's a patient level model. Then you want to take all of the data from that model, all of the patients that were diabetics, and go after the diabetics with complication, because that's where you're leaving money on the table, where you're already providing complicated care, but you're not getting paid for it. But your unit of analysis isn't even the patient. The unit of analysis is now the document, right? And then you swap out the unit of analysis from document to finding free text evidence of the fact that a clinician delivered a continuous glucose monitor read, which helps that clinician get paid an additional $550. If you can do this across millions of records, suddenly you can help healthcare institutions get paid in this value-based model. And you can do it automatically, and not just for one problem, but for many problems. And the final example, and this is work we're doing with a health plan. They're a Medicaid plan, and so They invest a lot of money to stabilize the health of a population. This will be very familiar to anyone who's working in a risk model. If the members in that plan leave after 1 year of enrollment, they take a real financial hit, not only the acquisition cost, but all of the cost to stabilize the health of that member. They have no idea. And also, if people leave after 1 year, it may be safe to say that they're not happy, which affects star ratings and all these other things that health plans care about. So they use this approach to, number one, identify why people might leave, which is not something that you can answer with a query or with traditional approaches. And what they learned in using this approach is a couple of really interesting, I guess it starts as evidence, but then you follow up on it and it turns into anecdote, and then you follow up on that and it turns into improved care, or improved, in this case, operations. So it turns out that they hot-spotted a bunch of clinicians that were losing a bunch of members very quickly. Well, it wasn't about the clinicians. Those clinicians were in one part of Chinatown, and then they went out to the field and saw that their competition was blanketing 3 large apartment buildings with benefits that they couldn't offer, or at least they hadn't thought to offer, and there was a mass exodus just in that part of town. They also discovered that there was a real issue with the way one pharmacy was handling this sort of healthy benefit gift card that they were giving out. So it turned out that when their members were coming up to the counter and dropping their items that they wanted to purchase, the pharmacy was using judgment to say some of those items are not healthcare related and to deny payment, right? So their case managers knew this, but it never would have come up to management. It's sort of anecdotal until the data teaches you to look there. And the other thing that they're doing now is they're producing rank-ordered lists of the members most likely to leave. And for the first time, they've created proactive call scripts to get out ahead of the problem. And that was a big challenge for them. They only are used to inbound complaints, but now they've changed their model because of data to do outbound proactive outreach, which is just a very different but real strategic advantage. So this paper came out 2 months ago. It's a paper, and papers are kind of boring, but it was super exciting for us. Because what it was a team of researchers at Dartmouth published a paper using an early research version of the software that we had created from the bake-off and all that. And they used it to automatically detect falls from inpatient stays using the free text of electronic medical record. And their sample size was in the small hundreds. And nobody on their team was a data scientist. Nobody knew natural language processing. Nobody knew machine learning. These guys are friends. We worked with them 6, 7 years ago. They didn't even tell me that they wrote this paper. And the last time I was working with them, it was on behavioral health issues. And this, to me, is what's most exciting, because this is where we need to be. A group of people that understand the problem and the data, using a tool like you would use your cell phone to identify the people that needed their help so they could provide better care. And if we move toward a value-based world, the number of questions that we will need to answer absolutely requires that we, the experts, get the hell out of the way as quickly as possible. So I hope, in trying to wrap this up, that I've convinced you in some way, shape, or form that, number one, this is happening right now. Can you just show of hands, do you guys believe that this is happening right now? Some skeptics, or just you're bored because I've been talking for so long? Number two, do you believe, show of hands, that the ROI in healthcare will be greater even than the ROI in other industries? That's a tough one to swallow because we've watched that light at the end of the tunnel seem distant for so long. I guess the last question is, do you believe that it will fundamentally change what we consider analytics today? Show of hands. Those that don't have your hands up, get a good look at the people with their hands up. You'll be asking them for a job in 5 years. I'm just kidding. Listen, obviously I love this stuff. I've been eating, sleeping, breathing it for a long time. If there's anything I can do to help anyone, whether through bouncing ideas or making connections or sharing what I've done, sharing the mistakes that I've made so you can avoid stepping on the same landmines, it would be my absolute pleasure to do so. There's my contact information. Thank you for your time and attention.
Thank you for a very interesting presentation, and I completely understand and appreciate what you're conveying. It seems to me the problem isn't about analytics, though, and it's not even necessarily about healthcare. It's an economics issue. And the issue is that most consumers don't understand when they receive good healthcare or bad healthcare. Like my father, were raised to accept the healthcare you get and not question it because that could be detrimental, and we're not informed. How do you solve it from an economic standpoint so that people care about and understand and engage to shift the vested interest in the healthcare system we have in the U.S.?
Yeah.
You know, just real off the cuff.
Just a softball? You're giving me a softball at this hour?
Thanks.
Yeah, no, so, I mean, that's the question, right? I mean, the reason why healthcare in general can't count the number of people that die by accident is because we have not been incentivized to do so. Price transparency, definitions of quality, these are the big challenges that our policy makers struggle with, right? APMs, AQCs, ACOs, 20 different flavors, moving the teeth back 1 year in MACRA. I mean, it's a real struggle to create policy that can incentivize healthcare toward quality in ways that we haven't been able to do. If I had the answer, I'd give it to you, because all of us need this to be answered as quickly as possible. And I debated how far down this road to go in the design of this talk, because really I do believe that's everything, is, as I said, economics is everything. Policy in healthcare dictates our economics, and policy eats culture and strategy for breakfast in healthcare. I don't have the answer. What I can say is we're closer now to paying for quality, which means analytics will move away from simply reporting on what happened. Now, one thing I want to say very quickly, the greatest threat to progress, to the type of progress I'm describing here, is a reversal back toward fee for care. Or right now, if you're a policy nerd and you're paying attention to very specific policies which could dictate whether or not analytics remains reporting based on mandated measures versus true competitive advantage based on analytics. The one bit of policy that I'm watching that is a fork in the road is MACRA. And you have on one hand MIPS, which is really largely loaded up with more reporting and drop downs and checkboxes and frustration. And this is my opinion, the alternative to that are the APMs, which are, they define an outcome, they define a type of therapy or treatment, and they say, hopefully they add risk to this, which they haven't done effectively yet, but once they layer in risk of the patient, the sicker or the healthier, then they'll start saying, we're gonna give you X dollars to get it right. And that's the closest thing to, I'm gonna give you $25,000 for a car, now you figure out how to make it most effective. Yes, hi.
Hi. I believe, first of all, I love the fact that you're talking about the notes that come on the electronic medical record. I know that nurses often do the right thing, but they don't always document. So how do you drive documentation in order to do your work? Do you think natural language processing, meaning the notes, will make that better?
Yeah, so I have long said that clinicians need to dictate in binary, but no one listens to me. Not to be glib, I mean, the point is, if we in the analytics space think that we can dictate what gets documented and how, what gets documented will be dictated by the incentives. The incentives are dictated by policy. It's our job to not wait for a perfect world. And if you want to chase the windmill and try to get nurses to document more effectively, I can tell you that many a really good people has lost a career to that, and I didn't feel like waiting, right? And I think if we're going to start using the data we have, clinicians are furious with the quality of electronic medical records and the experience that they're having with it. I just recently wrote an article where I made the argument that analytics can help maybe make it a little bit more worth it by taking the data we have today and turning it into insight to help doctors provide higher quality care. And that's an opportunity as opposed to complaining about the lack of quality, but you cannot do that using reports or queries or SQL, right? You can't do that with traditional statistics. So if we're going to move now, you have to be able to accommodate messy, inaccurate, unstructured data, which gets back to my argument that we need to start using these technologies, and gets back to not my argument, but the objective fact that we have 40 years worth of empirical evidence suggesting that we are past the time or the challenge of proving that this stuff can work.
Hi.
Hi.
Thank you very much. It's a very great presentation.
Thank you, sir.
And also, the work you're doing for this field, and you're done and you're doing so far, is excellent.
I appreciate it.
Probably this question is more subjective. The question is, in the field of machine learning, right, so data is all about. And
Data is what?
data matters a lot. So the more data you have, the more accurate results or more trends you're going to get. So in that line, all our data is mostly related to ICD-9 so far, and we have been moving to ICD-10, right? So if you take ICD-9 codes and do your training sets, mostly I'm talking related to supervised learning, and you apply this on a ICD-10 set, how are you going to get an accurate data results?
Yeah, so there's a couple of loaded issues in there. Number one is the assumption that we should be working with claims data at all. And I would say that it is a piece of the puzzle. There's also a number of studies that have shown that your assumption of more data leads to better predictions is not necessarily accurate. And here's why I say that. Studies have shown that having 10,000 versus a billion rows of claims data doesn't matter, depending on the problem, right? Because claims data is such a loose surrogate of what's really wrong with a patient that having more of it doesn't necessarily get us past this rather disappointing area under ROC that we see time and time again of between 0.68 and 0.75. And we play games by focusing on the top decile and saying, hey, we got a 0.85 there, and maybe that's okay, depending on what you're trying to do with the results. So what we have found, in that example with trying to predict which members are likely to disenroll, or even the work we're doing right now where we're focusing on preventable readmissions for 5 different disease categories as part of a case management effort, we're using claims data and we're using home visit notes, HRA, ADLs, Likert scale survey data, like whether or not a person is capable of being mobile or toileting themselves. And that is where real value is gained. It's not in having more and more and more claims data. We can do really accurate work with only 10,000, 5,000, and the fall study, only 300 or 400, if the data is richer and wider, as opposed to being narrower and longer. So the ICD-9 to ICD-10 problem, in machine learning, it is absolutely the truth that if you train on apples, if you train on EMR data, you can't just apply it to oranges, ICD-9 claims data, right? So that is a limitation of these approaches, is if you're gonna try to prevent readmissions, whatever data you bring in is the data you then need to apply it to. And so what everyone's had to do that's worked with claims data for any problem is they've had to have mappings from ICD-9 to ICD-10, right? But here's the thing, if you're using a rules-based approach to map from ICD-9 and ICD-10, and then you're applying rules-based logic to ICD-10, be aware that every mistake you made or your clinicians made in capturing that code and then you as the analyst in mapping it propagates. So that, listen, don't be surprised if you go from 13,500 codes that are between 20 and 50% accurate to then adding another 55,000 codes, your accuracy is going to drop off a little bit, especially when the people who are actually coding this stuff hate the fact that they have to do it. And you won't be surprised to learn that I was at a conference the other day and a clinician stood up and said, I won't name the EMR vendor, but they said, no matter what you do, if you're using this EMR tool, never admit that you're dealing with the diabetic, because you'll spend the next 20 minutes clicking yourself out of the EMR to get back to focusing on the patient. But it's a good question. These are real problems.
Yeah. My second question is, those who are planning to or willing to try this machine learning using the open source tools, I'm sorry if it is a wrong question for you. What kind of tools that you recommend, especially for healthcare? One is, in terms of machine learning, probably you can choose some of the libraries that are available. And the second part is NLP is definitely a major factor in healthcare. So what kind of open sources that you recommend for, especially for healthcare?
Yeah. I'm going to be here for a couple more hours, and it depends on the problems you're trying to solve. So if you want to come see me, I'll lay out my favorites.
Okay, thank you.
You're welcome.
A lot of smart people work at institutions that have regrettably adopted Epic, and I'm wondering what you'd have to say about how do people who want to take initiative to use analytics to solve problems who are at an institution that uses Epic, practically speaking, get at the data, do the work without going through years of administrative hassle.
Yeah, so you're trying to get me to step on a landmine and talk poorly about Epic. Here's what you need. Here's what everyone needs to. So I've spent years. Every single organization I've joined and problem that I have chose to focus on started with one question: will I have access to data? And surprisingly, the answer is not always yes. And so you have to be very strategic about where you work and what problems you focus on. The reason for that, and the reason why every IT department in healthcare right now is not super excited with the requests of individuals, even high-level individuals, trying to get access to the data, is because of this incentivization of the rapid adoption of electronic medical records. We still get paid for keeping these systems running and for seeing more patients more quickly. The vast majority of healthcare is still paid in a fee-for-service model. In that model, if you can collect $17,000 to adopt Epic, I can tell you that Epic and that hospital are working as hard as they can, as fast as they can, to simply install and not break anything. And so they just don't have time to focus on the things that don't matter, like improving the quality of care.
So I wonder if you can suggest a workaround.
Yeah, move to Canada. I mean, no, listen, if the incentive, if the incentive isn't there, it's really hard to get organizations to give the data. I get a huge kick out of people talking about data sharing as though all hospitals are going to, I mean, they don't even share it with the people inside the institution that are trying to improve care yet. But if we keep going to value-based care, they won't do it out of the kindness of their hearts. They'll do it because their competitive advantage is entirely predicated on their ability to use the data to become more effective. And over a beer we can talk about how we can trick some people in your organization, but I don't know how far to go with that.